Okay, so today we are going to discuss nasopharyngeal carcinoma. A diabetic middle-aged Chinese man with ulcer in the nasopharynx on recent chemo and radiotherapy. Now presented with the current nasal obstruction, what are your differentials? What are other non-epithelial tumors can be here? Infection, abscess, trauma, hematoma, benign angiofibroma, malignant lymphoma, rhabdomyosarcoma, squamous cell carcinoma, liposarcoma, obstruction like adenite. Define carcinoma. Carcinoma is a type of cancer that develops from epithelial cells. And okay, so here is another question. Define sarcoma. So sarcoma is a malignant tumor which arises from mesenchymal mesenchymal cells or stroma of an organ. Carcinoma is a malignant cell which comes from epithelial tumors. Adenoma is a benign tumor which comes from epithelial tumors. Okay, what are the differences between benign and malignant cells? Benign and malignant tumors can be differentiated from one another based on the degree of differentiation, rate of growth, local invasiveness, and distance spread. Benign tumors resemble the tissue of origin and are well differentiated. Malignant tumors are poorly or completely undifferentiated and aplastic. Benign tumors are slow growing, whereas malignant tumors are fast growing. Benign tumors are well circumcised, where malignant are not. Benign tumors are capsulated, malignant tumors are not capsulated. Benign tumors do not invade the surrounding tissues, whereas malignant tissues does. Benign tumors remain localized to the size of origin, whereas malignant tumors are locally invasive and metastasize to distant sites. What is the SI units of radiotherapy? Coulomb per kilogram exposure, Gray dose, Sievert dose equivalent, or Becquerel activity. So these are the different radiotherapy SI units. Okay, so these are some, we'll later come to this. These are some extra points. What is the mechanism of radiotherapy? Ionizing radiation works by damaging the DNA of cancer cells. Base damage of the DNA, basis of the DNA. Single and double strand breaks and cross-link between DNA and proteins tissue, leading to cellular deaths. So we all know that DNA is composed of bases, ribose sugar or deoxyribose sugar, or and histone proteins. So this is like complete combination. So what they do, they break the different bonds, the different type of bonds. Risk factors for nasopharyngeal carcinoma: gender, twice as often as males, and like, okay, in this we have the modified factors and non-modified. Modified factors are salted fish, tobacco and alcohol use, and these are the some of the modifiable factors. Non-modifiable factors are family history, genetic factors, and gender, more common in males, ethnicity and race, most common in southern China, Singapore, Vietnam, Malaysia, and Philippines. And so, and you can modified factors are salted fish, as we said, and some carcinogenic volatile nitrous amines and absent virus. You can like make preventions. Patient had an oral lesion swab showing hyphae. This is candida fungal. What are the risk factors for the patient for oral candidiasis? Is okay. So any debilitating disease or any chronic disease like cancer, TB, AIDS, HIV infection, all these will mm, give rise to immunocompromised state. So in such cases, patient will have candidiasis. So as a complication of radiotherapy or chemotherapy, because it's a immunocompromised state, ulcer and dead tissue form following chemo radiotherapy predisposed to fungal infection, or being a diabetic. Diabetes is also a immunocompromised state. So in all these conditions, you will get candidiasis. What are the routes of spread of nasopharyngeal carcinoma? Lymphatic spread and local invasion. Where to spread locally? So okay, this is a beautiful diagram of the nasopharynx. So about the nasopharynx, you know from anatomy, about the nasopharynx we have sphenoid sinus and cavernous sinus. So it can invade sphenoid sinus and cavernous sinus to the base. Posteriorly it can invade the base of the skull, clivus, and anterior it can invade the nasal cavity and paranasal sinuses, orbital invasion, and laterally we have the parapharyngeal space and middle air cavity through eustachian tube. It can communicate. Oropharynx, uh, tonsillar pillars, and C1 vertebrae downward. What are the common lymph node tumors? Lymphoma, Hodgkin lymphoma, non-Hodgkin lymphoma, leukemia, and metastasis. How will you investigate for metastasis in lymph nodes? So tissue biopsy and imaging modality. Imaging modality ranging from ultrasound, CT scan, MRI, and PET-CT, and tissue biopsy is through FNAC, finite aspiration cytology, excision biopsy, central biopsy for histopathology assessment with or without immunohistochemistry. Okay, so we can quickly discuss something else as well. Immunohistochemistry. So which type of like how immunohistochemistry works? So it is through complement fixation. We have different type of immune responses: type 1, type 2, type 3, and type 4. You will remember from your medical school. So immunohistochemistry is type 3 basically, because cells has a different type of antigens, and so those antibodies react with it, and so these complement fixation, and so like they take up the different dyes basically. So remember that it's a complement through complement fixation.